Okay, ladies and gentlemen, thanks very much for joining us again tonight, 2 in 1 week. It's a bit much, but these are unprecedented times. So thanks very much for giving your time, and thanks very much to Dr. Amandeep Hansra, who's with us here tonight to talk to you all about how to conduct a telehealth consultation. Now, as is customary, we would like to acknowledge the traditional owners of the land in which this meeting is taking place and pay respects to their elders, past and present, and their families. Now, we did send out the learning goals before this, you registered for this webinar, so I'm not going to run through those again, but I am going to hand over to you, Amandeep.
Welcome everybody tonight, and thank you for having me. I was just telling Glenn I've never been so popular as I have been the last couple of weeks, which would be a great thing, except, you know, what we're facing is not necessarily a good thing, but it's great that we can use technology to help protect some of ourselves from the transmission of COVID-19 and also protect our patients. So tonight I'm going to talk to you a little bit about telehealth, actually doing the consultations and setting up your practice for it. I know that many of you may have attended a session already earlier in the week around how to supervise in times of telehealth. I almost feel like I should have done it the other way around, had this one first, but we're almost going to take a step back and say, you know, what is telehealth, what are we doing, and how are we setting it up, and then you being able to apply that lens to your work as a supervisor. So just to give you background, I'm a GP. I work here in Sydney, in Bondi, the epicentre, I think, in New South Wales of COVID-19 with all of our backpackers. They are all my patients, unfortunately. So telehealth has become really important for me. But I also have spent the last 10 years working in the space of telehealth. First, 10 years ago, helping with the After Hours GP helpline that's still in existence today, where I learned how to do a lot of telephone consultations in the after hours period. I mean, most of that was triaging. We didn't sort of treat people necessarily with scripts and referrals or medical certificates, but subsequent to that, I worked for Telstra Health, setting up their telemedicine business, where we did do video and we did scripts and certificates, etc. Again, for sort of after hours periods and for remote areas. And I've also set up a telemedicine service in the Philippines and done some work in with a Swiss company in telehealth. So I've had quite a lot of experience sort of across the board, but maintained obviously working in general practice, and now it's great to see all of it come together. So as of yesterday, we haven't updated these numbers today, but we had almost 5,000 cases in Australia of COVID-19 and 21 deaths across the country. And so telehealth has been very rapidly implemented across the board to try and protect healthcare providers and vulnerable populations, and try and help spread the transmission of the virus. So that is why we are all here trying desperately to learn about telehealth. But if we want to talk about what actually is telehealth, Glenn to move across, thank you. So telehealth is not new. It involves telecommunications, which could be a phone, or virtual technology to deliver healthcare outside of traditional healthcare facilities. So it basically means that you are treating or consulting with a patient who's not directly in front of you. So if we think back to telehealth, it's not really new. Back in the 1920s, RFDS was doing telemedicine in remote areas of Australia with two-way radios. So there are many people in Australia. I'm not the only one that's done telehealth for a long time, but it's just not at this scale and for this particular reason. So we've really focused on telehealth as a solution for bridging distance and access, not really as an infection control measure. So I think this has been quite a fascinating application of technology, but it's just people, you know, should be aware that it's not something to be afraid of. It's something that we've all been doing, really. Technically, when we pick up the phone and call our patients and give them results for their blood tests, we are actually doing a form of telehealth. So really, it's just a remote diagnosis and treatment of patients using technology. So if we move on to the next slide, telehealth encompasses not just live telephone and video, which is really what most people are talking about now, is doing a live video consult with a patient or a live telephone consult. But other elements of telehealth is also remote patient monitoring. Now, just a caveat, Medicare hasn't sort of funded all of this, just the live telephone and video. So patients using devices at home, wearables, recording their blood pressure, uploading that to a portal and having a doctor review it, that's all a form of telehealth. Store and forward is where you take pictures of something, for example, like a dermatological condition, you upload it, a dermatologist looks at it the next day and sends you back a result. That's a store and forward type of telehealth. And then there's also mobile apps that start to, encroach in this area of telehealth. So lots of different formats. Today we're really just talking about telehealth, telephone and live video. And the reason is because we've had to for COVID, but we've also got telehealth item numbers that have become available for us. So these are temporary items, only supposed to be in place for 6 months. And I think most of you are aware of, sort of what they cover, but just to quickly go over, I mean, initially they were supposed to be for the case definition, for people who met the suspected case definition of COVID or were vulnerable patients or vulnerable doctors. It was expanded as of Monday, the 30th of March, earlier this week, to cover over 222 items now. And it covers GP consultations, non-specialist medical practitioners, which would be non-BR GPs as well, nurse practitioners, specialists and consultant physicians, including psychiatric services, psychology services, including the focused psychological strategy items, and midwifery and obstetric attendance items. So it's not just for COVID-19 anymore, it's for all conditions, covers standard consultations, GP ATSI health assessments, chronic disease management items, autism management, pregnancy support, eating disorders, mental health, and some urgent after hours care. So the practitioner does not have to be at the practice to deliver these. They can actually be done from home as long as you're using the provider number from your main practice. We might just move over to the next slide. So as we said, they're in place until September 2020. The bulk billing incentive has doubled for items related to general practice, pathology and radiology. And this is for concession card holders and those under 16. The preference is for video. So the department will constantly sort of emphasize that they would prefer doctors to use video platforms, but they're not going to mandate it. And there is that phone consultation item number. So there's different item numbers, whether you do video or phone. And they have actually put in Medicare schedule that it's okay to use Zoom, Skype, FaceTime, Duo, GoToMeeting, any of those platforms. They're not going to specify which video platform you use, but they really emphasize that these services have to meet the applicable laws for security and privacy, for example, the Australian privacy principles. And for those of you that attended the webinar today that Professor Michael Kidd ran, talking about this, he said the department wants to emphasize that free platforms are not encouraged because many of them will not meet the Australian privacy principles and the other security legislation. So they're actually getting the Privacy Commissioner to comment on that further. So they're actually preferring people to use paid versions of these platforms or a health-specific platform. But we're going to talk about that a little bit further in the discussion because this is really about Medicare at the moment. So as I mentioned, you can do this from home using the provider number of your main practice. It doesn't include asynchronous channels, so the store and forward stuff I talked about before, you can't do that, you can't do chat. It has to be live. You have to have an audio or a video connection directly with that patient. The rebates are to be paid at 85% of the new item number. That's been adjusted so that it ends up being the same as a face-to-face visit. You can use the telehealth item numbers more than once a day, or a telehealth item number and then a face-to-face item number, as long as you have enough of a gap. So you can't sort of say, I saw this patient at 3 o'clock and then I bill another item at 3:10 and another one at 3:20. There has to be a reasonable period, and there has to be good documentation about the reason for having another consultation. It can't be just a continuation. The issues that some of the doctors have raised around getting consent. So I don't know if any of you looked at the fine print, that you had to get an email consent for people to assign their bulk for their Medicare assignment to you as the practitioner had to have sort of a written or an email consent and a signature, which was very limiting for a lot of patients to be emailed and then you emailing them back, etc. So they have relaxed that a little bit and said as long as you document that you get consent, even verbally is fine. So during the consult, and we'll talk about the consent sort of process in a consult a bit later, but you can build this into your consult and just get verbal consent and document that you have verbal consent. You can prescribe, order tests and do referrals. Medicare are happy with that. They've said that you do need signatures, obviously for scripts and medical certificates, but for other referrals, you can get away without putting signatures on those. So I want to talk a little bit about prescriptions because there's been lots of questions about prescriptions. When I have spoken to some of the pharmacists, they've given me some tips that they would like to sort of talk to the GPs about. One of them is that they do not want scripts to go via the patient. They prefer to get them straight to the pharmacy because of concern of reducing transmission of COVID-19. So my advice is to ask the patient what pharmacy they wish to get their script filled at. And so you're still giving the patient choice. I wouldn't say, okay, we're sending all of our scripts to this particular pharmacy. You know, I don't think patients would take to that too lightly. So, you know, you can have a sort of a rule around, you know, we're not going to start getting all these details of pharmacies that are, you know, 20, 30 kilometres away, but the nearby ones, you know, you can choose any of them and we'll get the script to the pharmacy directly. Pharmacies are happy to receive the scripts via fax, photo, text, email. Most of them are saying, look, happy for you to just take a picture of the script and send it that way. And unfortunately, the legislation still requires that we post the original within the next 24 hours, although I've been told by some people that it's as long as the pharmacy receives it in 15 days. So maybe you just need to post it within 24 hours and Australia Post might take 15 days to get there, I'm not sure. But that is still an issue about trying to get the scripts to the pharmacy. This is a very quickly moving area, and more recently I've been told that doctors are now being told just to hold on to the scripts and post-COVID we'll sort it all out, because it's really around audits for the pharmacies where they get audited and have to show that they've got the physical script. So I think just holding on to them for now is not terrible if you can't get the whole post thing working. So you do still need to sign the scripts. Sorry, I just saw that question pop up. So that's where you would sign it and then you would have to take a picture of it. Sorry, I'll just go back. Sorry, Glenn, just finish off that one for a second. The pharmacists also say that please try and use pharmacies that deliver, and they especially do not want patients to turn up with respiratory symptoms. And if they do, they should ring beforehand so the pharmacist can come out to the car and give it to them out there, or they can organise delivery. The ADHA is working with the Department of Health to try and fast track electronic prescribing, and I'm going to move on to the next slide to talk a little bit about electronic prescribing. So this might be stuff that you guys all already know, so apologies for that, but an S8 scripts, unfortunately you can't take photos or fax, that has to be the paper script. So just, yeah, I don't think that legislation has changed. So e-prescribing, the electronic script is basically, so it's a, you know, turning your paper script into sort of a digital format. So that electronic script is transmitted from your patient management system to a script exchange, and that's in an encrypted format. Now what happens is that digital format of that script becomes a legal document instead of the piece of paper, and that script data is then held on this exchange. The two sort of exchange providers at the moment are ERX and MediSecure. You can actually download their apps onto your phone, and what the patient receives is a token. So token can be by SMS, email, or it can be on their actual app, or they can get a paper printout and they have like a QR code on it. So then they can use any of these. So they basically just need to show the token to the pharmacist, and the pharmacist can dispense that medication. So that token is providing that unique code which the pharmacy uses to access, you know, all the information about that script. So what has happened is that legislation sort of changed in October last year, and then it's been a process of trying to get all the patient management system vendors sort of on board with all the technology changes they needed to make to enable electronic prescribing. And then it was getting all the pharmacy changes to happen, not just from a technology perspective, but also the workflows, you know, where they don't put a piece of paper in a basket and then take it up to the pharmacist. So all of that was going to happen slowly over the next year. Obviously, electronic prescribing suddenly become much more urgent. With telehealth, it works nicely and saves us the logistical challenges of posting bits of paper. So what they've now done is they've sort of relaxed some of those conformance processes for those vendors, technology vendors, so they can speed that up. And they're saying probably by the end of May, they're hoping to have a full sort of electronic prescribing sort of working. But what you can do in your practices is just make sure that you're registered and have activated electronic prescribing. And, you know, it's really a discussion with your existing clinical software to make sure that they have, you know, enabled that in your particular, whatever particular software that you're using, so that when it is turned on at the end of May, that you have that ability to use that. So just to give you an example, next slide, this is a digital health agency just showing how electronic prescribing might work. So if we just move on, Glenn, thank you. Okay, so we've got here James, who is our vulnerable community member who's self-isolating due to COVID. He's at home alone. He doesn't own a car and he needs to get his regular medications for his hypertension and type 2 diabetes. So the doctor does the telehealth consult, issues an electronic prescription via the token method. The pharmacist receives the token from James, so that might be through the SMS or the app, and dispenses the electronic script, and the pharmacy delivers James his medication to his house. So that is really where we just, you know, keeping these three people all very separate from each other and trying to prevent transmission of COVID. This is going to be the future anyway, with or without the telehealth. But at the moment, we're trying to get this sort of sped through. So let's just go back, take a step back to how we're actually going to set up telehealth in our practices. And this is where I think, you know, for a lot of people, we'll just move on, Glenn, to the next slide. There's a lot of people who are, sorry, I'm going to try not to read the questions at the bottom, but what app or token will James have? He may not, he may just get an SMS. And there is also another way of having an active script list with a pharmacy, where the pharmacy, you can activate that. So the pharmacy just knows when a new script has been issued or prescribed by the doctor, and they can organise dispensing of that medication. So I do think there'll be probably worth having another session on e-prescribing, Glenn, at some point from the Digital Health Agency, just explaining all those other methods. And he can also still have the paper if he wants, and the QR
yeah, great
code.
idea.
So just going back to the telehealth process, there's a lot of people panicking. You know, my phone went crazy where everyone said, you know, a little bit about telehealth, what platform do we need? What IT changes do we need? Do we call our IT provider? Like, what does this mean? And so my advice to people is just, you know, sit down and start doing some planning first. Like, the first thing you need to do is just get everyone that's going to be impacted by this change in a room together and sort of go through, well, how is this going to occur? Because it's a change that's not just going to affect you in your room doing your teleconsultations. It's going to be the reception staff, it's going to be the practice manager, it's going to be the practice nurse, it's going to be the patient, it's going to be the registrars. And it really does need to be seen from all the different perspectives of the flow and effects of what you do. And I don't know if people who are already doing telehealth have noticed that suddenly their admin, the reception staff have a lot of admin to do. You know, it's like, send this thing here and post that one and fax that one and email that, and you're giving them a pile of paperwork to do. So there is really, you know, impacts to everybody in the practice. And I think it's really important to have all of everybody involved in the decision making around how to design the workflows and what kind of technology is going to be required, and then how are you going to implement it and how are you going to review it. And I think it's really critical at this point to have regular reviews. And I mean, you know, every couple of days, sit down and go, what didn't work today? Like, what was just a stupid idea? I don't know why we did it, but, you know, we need to change it, and we need to change it for tomorrow. And I can tell you, even my practice, even with, you know, experience I've had in telehealth, you know, we've changed the process probably 3 or 4 times already. So you don't know what's going to work and what doesn't work until you try it out. And, you know, we just have to learn to adapt and be a bit agile. So just moving on to the next slide, we're talking a little bit about, we've already mentioned holding the practice meeting, setting up the required technology, and I think it's important to work out whether remote access will be required. So where are your practitioners going to sit? Because this really does change some of your workflows and processes. Are you still going to get doctors to come into the practice and work from there, where they have access to the patient management system quite easily? They have script paper there, they can sign things, they can hand it to the receptionist. Or are you sending everybody home? And this becomes an issue for supervision as well for registrars. How do you supervise them at home? How do they do all the admin things afterwards? What kind of internet access do they have at home? What kind of hardware and software do they have? Cameras built into their laptops at home? Do they have webcams? But also you do need to train people. And I think this is part of, you know, what's great with GPSA is doing here. And a lot of other providers have realized that it seems easy in theory, just switching from a face-to-face to a video or a phone. But there's just so many workflow changes that I think it can be a bit overwhelming. And it's not, and it's the efficiencies, I think, that people have fed back to me really get kind of screwed up, where you feel like you should be faster because you're not calling a patient into your room, but the clunkiness of all of the different systems and trying to get everything to work can actually mean that it slows you down. So it's important to, you know, to realize that this is a big change in a very short period of time, and just to, you know, be kind to yourselves and allow yourselves some time to, you know, to upskill and train. And the workflows, as I mentioned, are probably the critical part. So the technology is kind of interchangeable. You could switch from using Zoom or Skype or a healthcare specific platform. But the thing that could make or break the whole thing is how you design the workflows. And it's important to communicate those workflows, not just to your staff, but also to your patients. And I would do it in multiple ways, you know, send them an SMS. We've now changed. Our practice is now doing X, Y, Z, and this is the process for getting an appointment. This is how we're going to conduct it. This is the platforms we're going to use. But, you know, we're going to maintain the same quality, and we're going to protect your privacy and confidentiality. You know, just giving them that reassurance, because you're going through a change management process, but so are all of your patients. And, you know, they're already fearful and scared, and then suddenly they can't see you in person. And, you know, they're waiting for that reassurance from you that it's going to be okay. So I think just your messaging has to be around, you know, we're still here for you. We're just changing how we're going to be there for you. So change your website, your on-hold messages, update your practice templates, and the workflows for admin activity, we talked about it, and the triage process, and what to do if you need a face-to-face visit. And I will tell you a little bit about what we do in our practice, about how we manage that, but we'll just, I'll do that a bit further on. So just prior to actually doing the consultation, so you've had your practice meeting, you've figured out how you're going to do it, you've got the workflow, you know, figured out, and then you're about to do a consult. So whether you're at home or whether you're at the practice, it's really important to make sure you've got everything with you that you need. So if you're at home, it's really important that you have remote access to the clinical notes. It's very hard to wing it and do a consult for a patient without their clinical record. I wouldn't advise it. And where do you document information? So try, you know, I'm pretty confident that most places can get TeamViewer or something to be able to get into their server-based patient management systems. And if not, you know, is there a way that you can do it from the practice? Check that you're doing this consult via video or phone, and my patients have been choosing, and so before every consult I have to figure out, am I switching to phone or am I doing a video for this patient? Make sure you have a private space to conduct the consult. Don't do it in your living room or, you know, in your front porch. I think that's all common sense, but people kind of forget. Having a Zoom meeting or a webinar like this is fine here, but, you know, you've got a patient who's not expecting people to be walking behind you, or for them to hear other conversations going on. Test your technology before you do it. So do a couple of dummy runs, and especially with the registrars, doing dummy runs of supervision is really critical to give you comfort and give the registrar comfort, especially if you're all in different areas. If you're at home, the registrar's at home, you've got, you know, your receptionist is somewhere else, and you're trying to run a workflow, just do a test call. Receptionist becomes a patient and tries to call registrar and has a consult, and then you they call you in, you know, into the call to have you supervise something. I mean, just got to test it out a little bit if you've got a chance. If you are doing video, always have a patient's phone number. The number of times video consults, you know, fail for connectivity issues or whatever else, and being able to back up with a phone call is really important. So make sure you have their phone number. And I mentioned about the record. So just moving on to the next slide. So we're about to do the consult, and there's sort of flows in how you do this. And I know some people are just like, look, I'm happy to just pick up the phone and have a call like I do, you know, in person. I find it useful, and, you know, you don't have to take my advice, is to actually have a structure around the consult. It just helps me not forget things and to make it feel as similar to a face-to-face consult as possible. So you contact the patient, you confirm that they can hear you and see you, and most of you are probably doing that because the technology isn't 100% always working, and sometimes they can see you and sometimes they can't hear you. And I've done consults where we're looking at each other on video and we've actually got the phone going as well, and so we're kind of talking over the phone but we're doing a visual video. So you've just got to be a bit creative in how you overcome some of those technical challenges if you do go down the video path. Check their identity. It's kind of a given when they walk in the door that you know who they are, and even if they're a new patient, you kind of go, yeah, they look like a 50-year-old male that, you know, might be called, you know, John Smith. But, you know, if you're on the phone, it's interesting. You can sort of be a bit deceived and you think you're talking to somebody and you're not really even sure who they are. So always check their identity, usually doing 3 points. So, you know, their name, their date of birth, their address or their phone number, because you will need the phone number to call them if things don't work. But also making sure that the person they're calling on behalf of or having the consult for is actually in the room. So you get a lot of patients a parent who will call you about their kid and their kid is actually not even in the house. And to me, that's not really a consult you can do. And it happens more often than you think, especially if you're doing it over phone. And you start to say, okay, can you go over and check, you know, if you put your hand on the kid's tummy, is it sore? And they go, oh, he's not even here, he's at his dad's house or something. And, you know, makes it very difficult for you to even have that consult. So I know it sounds like stating the obvious, but just say, look, you're calling about your son, is he there with you? Always just check that everyone who is on that part of that consult is comfortable to continue. Are they seated somewhere comfortably? Are they stable? And you can do that quite conversationally. You don't need to do it in a way like, here, I'm going to do your Dr. ABCs. You can just say, look, you know, we're going to be on the phone for a few minutes. I just want to make sure that you're comfortably sitting and that you're not in any extreme distress while we're chatting. You don't have extreme pain or discomfort. Or, I mean, I've had patients do whole consults with me and at the end they're like, yeah, I've had this massive trauma on my leg and I'm bleeding, but I really was just calling about my cough, but this thing down here is really bothering me now. I'm like, you should have just told me that at the beginning. I would have dealt with that first, because you can't see them on a phone. It's just important to ask some extra questions. So just check that you get their consent, that they're happy that this is a phone or a video consult. And also this is a part where I build in the consent to assign the patient rebate to the GP. I'd love it if we can get rid of that, but, you know, at the moment we have to do that. And then you do what you would normally do in a good consult, taking the history, doing examination. And this is, you know, something you should teach all your registrars too, that just because it's done remotely doesn't mean that you cut any of those corners. You still need to do all of that. And always check when you finally give them advice that they understand it and repeat it back to you. Just going back, sorry, I just missed the examination. People always get a bit weird and they're like, how can you do examination? And that's, I don't mean an actual physical examination, but I mean that is addressing the things that you can over the phone or over video. And again, that's being creative. So if somebody has got shortness of breath and you obviously can't look at them or listen to their chest, it may be, you know, let's see how many steps you can climb today compared to yesterday, you know, before you get breathless and have to sit down. There are some particular scores and things. The NHS have done a lot of research in this area. And I think one of the scores they're using is a Roth score for COVID assessment to see how breathless a patient is, and it correlates to SATs of a certain level. I don't have it in my slides here today, but you can look that up. So there are some tricks and tips that you can use along the way for examination, but you do have to be a bit more creative in the questions you ask. asking how active a child is, are they actually able to get up and, get off the couch, and, are they rousable? Like, I mean, you just have to go through all those questions instead of being able to do it yourself. When you get to the end of the consult, it's really important to check that there's nothing else they want to say or they want to talk about. And I know sometimes in person you hate asking that question because they'll come up with 10 other things, but on the phone it's so definitive when you put the phone down, or on video when you cut the video out. They can't just run back in the room and say, hey doc, I forgot to get my script for my tritase or something. You do have to just ensure that they're warned that you're going to hang up, so that they feel like they've finished their consult and everything's done. But always give them a disclaimer about what they need to do if they get worse, or how to contact you again if they need access to medical care. Just again, because there's a lot of anxiety at the moment that people are afraid, okay, my doctor's now gone virtual and the next step is they're going to disappear. So it's like, we're still going to be here for you. You might still follow the same process, but we can have another call with you next week or another video consult. So I'm just going to move on to the next slide. So the admin part is the painful part afterwards, where you have to work out what do you do with all these bits of paper that we're so used to dealing with in the practice setting. So as I mentioned, you've got to have signatures for scripts and mostly for medical certificates, because employers will require that. But you don't necessarily need it on path or imaging requests. And talked about the e-prescribing, and this is where there are some things that we can put in place that might make it easier. So if you've got secure messaging turned on, great for doing referrals and saves you printing that paper and having to get it to the patient. Unfortunately, there's a lot of people who've had to resort to using faxes again, which in the current environment, I'd say use whatever you've got. And even though there are lots of issues and challenges around security of things like email and faxes and other things that we're trying to move away from, or trying to find better ways of doing things, I think at the current state, the college and the Department of Health have sort of said, whatever you need to do to get your patients care at the moment is okay, and we will over time address some of these issues to get you better communication methods. So if you've got things that you can use, turn them on, please, like secure messaging. So when not to use telehealth. So telehealth, you cannot do telehealth for everything. The company that I worked for in Switzerland who did telemedicine, the highest rates they had were about 60% of what they call telecare, which means that 40% of patients definitely still need a physical examination. And I think it's always, going to sit around 50-50. And, the goal isn't to go 100% virtual, and I would never encourage or promote that. I think it's about recognising the limitations of where you can't do telehealth. So obviously, no brainer, if your patient's got a serious symptom, injury, illness, you can't do that remotely. You need to physically see them, or they need to go to the emergency department if it is really serious. There are some things that just can't be done without a physical examination. If you need to do a gynae exam, if you need to do, an antenatal check, or, you need to give a flu vaccination. I mean, some obvious things. But I'd also not use telehealth for patients who are confused or not competent. So dementia, delirium, sometimes I wouldn't say age is a barrier, but you might have some patients who are not comfortable communicating over phone or video. You can try some tricks and say, look, would you like, if you've got a patient who's a bit older who doesn't feel comfortable, they may want to do a telehealth consult with you when a family member can be with them. Their daughter or son's coming to visit, and they can help them navigate, on an iPad, a video consult, or on the phone, with having someone else there as a support person. If a patient really doesn't want it, they're anxious or nervous, don't force them, don't push them. And if you can't do it because you're self-isolating, or you are a vulnerable person and you don't want to see someone face-to-face, just make sure you've got arrangements with another GP, a colleague, or someone that you can refer the patient to. And it's the same with the registrars, just encouraging them, to have that follow-up physical option for patients. I think this is where we have some of the issues with completely online providers, is that there isn't that ability for them to refer that 40 or 50% that need to be physically examined. And then those people, you end up just duplicating services. They've had a telehealth consult, and then they get told, okay, go find a face-to-face doctor who's going to go and see you. and we haven't really helped the patients. So I just think really important in your workflows to go, well, how are we managing patients that need to be seen physically? And obviously hearing and speech issues. So video might work if people can lip read, but otherwise it can be difficult. And also patients who English isn't their first language and who might struggle a little bit anyway, adding the extra barrier of a phone or a video might be harder, and you might actually want them in person. So as I mentioned before, the NHS has done telehealth for a long time. They have some really great guidelines. This is from a site, BJP, from Oxford University, and happy to share these around, but it goes through some of the practice setup, which we talked about before, how to do a high quality consultation, and that's some of the things that we've talked about. They are really trying to move to video over there as well. So you'll see that there is quite a focus on getting video up and running. And then their next flow chart on the next slide is actually for patients. So I think it's really important to get, yep, you can move that on, Glenn, is to also give instructions to patients. I mean, they also are going through a massive change, and for them to have a good experience, you can give them some tips and tricks of how to do that. So it's similar sort of thing, making sure they're in a quiet place, making sure they've got good internet connection, testing their audio and video before they see you, having their phone there as a backup, and you instructing them that you will call them if the video cuts out, because otherwise you're playing phone tag, calling each other back. Look at the screen, don't have you kind of looking up at your face, that sort of thing. So these are great resources if anyone wants to get access to them, the site's there. So there are lots of COVID-19 workflows available online too. Again, NHS has put some great ones out. The RACGP is in the process of publishing some of those over the next couple of days. And this is pretty much what we do at our practice. The patient goes online, books an appointment, and they can only book telehealth appointments online. And then we have separate clinics, which might be a flu clinic where they can come in just for flu shots, or an antenatal clinic. We've got a couple of others where we've decided these are face-to-face that sort of clinics that have to happen. The appointment takes place with the healthcare professional via telephone or video. They do their triage, and people have asked me, do you get your reception staff to do the triage and decide who's suitable for a phone or video or a face-to-face? I'd say I would avoid it if possible, unless your reception staff are really, quite comfortable from a clinical perspective, because it can be hard. And, you're asking them to make some pretty big calls about someone not being seen face to face. So if possible, I think sticking to the method of the patient booking that telehealth appointment and you being the one that does that consult. And so you either resolve the patient's issue and, you finish that consult off, or you organise a face-to-face consultation. And at our practice, we do them at the end of the day. So, we close at 9 or 10 o'clock at night. So the last, hour or 2 hours or whatever might be all the face-to-face consults. So we've got time to prepare if we want to put PPE on. We've got processes in place for them to wait outside, get a mask on, etc. And we're not mixing them in with. Sorry, I just saw that pop up of Chris's comment around making sure no one else is listening into the consultation. Really good point. And also mention to the patients that they probably shouldn't be recording the consult. That might be, it's not necessarily illegal in every state, but it's harder to see over phone and video whether someone's recording what you're saying, and that can be a bit unnerving. So back to this workflow, and then you organise the face-to-face consultation if and when you need to do it, or if you decide that they need to go to the emergency department or to a respiratory clinic, you can refer them there. So again, lots of these workflows online that you can look through. So Glenn, I'll move on to the next slide. So just some tips if you decide to use video. Make sure that your lighting is good. Don't have bright light behind you. Try and be face on, as we mentioned. You just don't want these weird angles. It's just kind of off-putting for the patient. I think they just want to see you as they would see you potentially in real life. Check what's in your background. I know it sounds silly, but some of us just don't pay attention to what's going on. I've, reviewed consults where, had animals running across the front of the video and all sorts of things happening. wear appropriate clothing, especially if you're working from home. You know, wear pants. I know that sounds silly, but there are people who go, well, it's great, wear my pajamas or whatever. But if you stand up to go get a piece of paper or something, they can see all of that. If you're on video, have the phone number, as you mentioned, as a backup. And please don't have people walking behind you, especially if you've got kids. And we don't recommend you record the video. So some of the services I've worked for, we've actually recorded audio because we've had to do audits, government services. So I've audited a lot of, consults of doctors, but we never record videos, not recommended. I don't know where you'd store it. And you don't normally record your video, record your consult. So the most important thing is documenting all of the clinical notes, and in a way that identifies how the consult occurred. So write, this was done by video or done by phone, or if you had to switch, you've got to write, when you switched, and any issues that you had in hearing or seeing them, because that all just for medico-legal purposes to defend yourself if anything did come up. So there are a lot of telehealth players out there, and there have been for a number of years, and many of you may not be aware of them, but this is a sort of a bit of a landscape of different telehealth providers. And a lot of these are standalone telehealth services, not necessarily platforms. They're actually services that have lots of doctors already attached to them. Some of them are in dermatology, some of them are in mental health, but you might see some of these companies come up, in discussions, especially around now, because they're all a little bit happy that there's some Medicare rebates. So I don't think you necessarily need to go to a provider that has doctors. If you're looking for a platform, there's lots of platform players out there. Some of these do provide just platforms. There's just to give you an example of the telehealth market is certainly crowded and busy. And I would just, have a conversation with your patients, because they might come to you and say, hey, there was this ad that popped up on my Facebook feed that said there were doctors that do bulk bill consults online. Why can't I just get my script through there rather than come and see you? And I think it's just important to emphasize the importance of maintaining that continuity of care with your GP, that you may not get the information from some of these providers, that you may not get, any communication back from them. They may have a place. I'm not going to sit there and criticize, what they all do. And then, maybe in the after hours space, or if it's an emergency, but I think it's really important that our patients are aware of the importance of maintaining their connection with their regular GP, because I think this is going to become an issue we're going to see coming up. So let's just move on. What platform? Lots of people are asking me this. Now, the department have very much sort of emphasised today that they do not really recommend using free platforms. We have an issue really with some of them. I mean, you don't know if they're encrypted end to end. We also have an issue with ones that aren't Australian, where they store data and obviously patient health information. There are regulations about protecting that data and making sure it stays in Australia. And I guess if you're exchanging information on any of these free platforms, we don't know where that information goes. There are paid platforms that are versions, upgraded versions of the free platform. So Zoom has Zoom for Healthcare that you could then go and use, which obviously has HIPAA compliance. So HIPAA compliance is more relevant in the US, but it definitely makes you more comfortable that they've met some of those privacy standards. But in Australia, we don't have a HIPAA equivalent. But there are, the Health Direct video call, which is powered by CoView, that one has HIPAA compliance. It's an Australian company, but I'm not sure some of the others may have, and I think it's worth looking into them. But there are a lot of providers that have come up recently who do or provide healthcare specific platforms. And what's the benefit of having a healthcare specific platform versus a Zoom like what we're using here? I guess the benefits is a lot of them are integrated in some way with your existing workflows. So for example, the Health Direct video call has a waiting room function. So it sort of treats it like it's your virtual practice online. I think Zoom for Healthcare does something similar. Some of these platforms also allow you to exchange documents with the patient. So you can actually put up documents in the video call and they can see them, and you can some of them have whiteboard functions where you can draw things, and some of them have form functions where you can get them to fill out the form, or that you can fill out the form. So there are added benefits for some of them just by having that extra functionality. If you're nervous, you're scared, you're just getting your head around telehealth, you don't necessarily have to turn on all this extra functionality, but it's just knowing that that is out there, and some of the health ones are a little bit more amenable to working with your other systems. So just to give you an example, this was me last night on the next slide, and parent did give permission, but I've just locked out at face. But so I actually had the video sitting next to my patient management system, and I was typing notes in there and chatting to the patient, and I, had a look at her throat, got her to open her mouth. I actually find video better than phone for me personally, and I know majority of doctors are doing phone calls at the moment, which is fine. I've spent many years doing phone calls, so I probably am, okay moving up to that video thing. But the other unintended consequences of doing phone calls is the feeling of loneliness. I don't know if anyone else has experienced that, where you're just sitting there phone call after phone call and you don't see anybody all day, especially if you're working from home and you don't see your reception staff, or you don't see your other GP colleagues. And I find video, just having someone physically interact with you a little bit, even if it's on video, it's a little bit more satisfying than just phone calls. But anyway, this is sort of my setup. So I'll move on to the next slide. So my tips really are, the technology, yes, it's an issue, but really getting the workflow right is probably the main thing. And I think that is taking that whole team-based approach. And obviously for supervisors, it's the added element of how do you remotely supervise registrars and provide them training and support. And I definitely think for Term 1 GP registrars that, preferably if they can do it from the practice and try not to have them at home, because it can be challenging trying to learn general practice and then trying to learn all this at the same time and have no one else around. Definitely get secure messaging. If you've got it, use it. If you don't, get it. E-prescribing, as we mentioned, is hopefully coming, so make sure your practice is ready for that. Technology, as I said, can be simple as the phone and as elaborate as a video tech platform that has integrated payment gateways, bookings, triage tools, etc. But don't get overwhelmed by all the extra bits unless they're going to actually add value to your workflow. And if you're using your phone, don't use your personal phone. I made a big mistake of doing a Skype consult once, and some patient of mine who has my personal ID now tells me every time something new happens in his life, and I really, don't need to know. But it's very important to not give out personal details. So set up a new whole Skype ID or a new WhatsApp number if you're going to use those platforms. But as advised by the department, they prefer you to use paid platforms. And I know it's a bit cheeky to say, okay, use a paid platform and pay for something else, but just as a note, GPs should have access to a free platform through their PHNs, and that's the Health Direct platform. So if you don't have a platform already and you want to get one, contact your PHN, because they should be able to give out licenses to GPs in their region. It's not very widely advertised, but that is a service that's available, and there are some GPs who've done that already. And yeah, just don't try and do consults without clinical notes. I really advise you working hard to get remote access or work from the clinic, and be creative with your examination. So my last slide really is just lots of resources available, and I don't want to overwhelm everybody because you're probably sick of getting all these different emails from all the different bodies about telehealth and COVID and all the rest of it. But College, AMA, ACRM and ATHS are probably my sort of four go-tos at the moment. ATHS is the Australian Telehealth Society, and they've got the great links to the UK-based resources as well, to Oxford and BMJ and NHS. Don't panic. Please don't panic. It's going to be okay. Just make sure that your safety and quality is maintained, and also ask assistance from colleagues. So if you've got a practice down the road who seems to have done it really well, just go knock on their door and say, hey, can you share with me what you did with your workflow? What have you put up on your website? How have you told patients? I think we're all in it together and we can all learn off each other. And the next slide just has the links of the resources. So Glenn, these, I'm sure you can make them available to people. And I think if you've got this is probably enough, because again, you don't want to get overwhelmed.
We'll send those out to everybody.
Great, thank you. I might stop there because I feel like there's lots of questions, and I, want to be able to answer some of those. And I don't know what time we have to kind of get off. Probably very soon.
Yeah, absolutely. So for those that aren't familiar with the secure messaging, where would they go? Where would they get that? How would they go about?
So PHNs, you can contact your PHN. The Australian Digital Health Agency has some information. You can speak to your clinical information system, so your patient management system. But usual ones: Argus, HealthLink. There's a couple of others, and I would advise just switching that on. I mean, we use it to get pathology results, radiology results. I don't think many people have been using it for referrals to specialists, but that specialists are increasingly having access to secure messaging. So I think it's a great time now, where we get away from faxes and posting things, that we can start using secure messaging. But your PHN should be able to point you in the right direction.
Yeah, we had a question about around the scripts and different things like that, and the person asked, "Is it necessary to get your own printer? Do you have that in your own setup? What is your?"
Yeah, so it's complicated. So what we do in our practice is we actually print from home, and it prints out in the practice. And in the morning, the reception staff sort out all of the scripts and get them signed and get them sent off. It's not ideal. Like, I haven't figured that out. I mean, I have the ability to print at home, just not all the other doctors had that. And so that was a process that was set up. But certainly if you've got a printer at home, you can bring home some printer paper and print it off. Previous services I've worked on, we just did it at home that way. And we actually even did the posting within 24 hours. I can't believe we did that for so many years, and actually posting scripts. But hopefully they're going to get rid of that as well.
Yeah, there's lots of questions here about S8s. We've got a question about what is your suggested process to get an S8 script to a patient or pharmacy exception for palliative care?
Yeah, so unfortunately they're saying, pictures and emails and things of S8s are not okay. So they still need the paper copy. So you need to get that paper copy either to the pharmacist or to the patient. And so that may be the one where you do have to arrange a pickup service where, if you don't want the patient coming into the practice, whether they sort of do a drive-by and pick up the paper, whether you do put it in the post. I mean, again, you worry about people intercepting that. Or if there's somebody, who can do a drop-off to the pharmacy of a bunch of scripts and leave those there. I'm not sure whether, they've definitely said the pictures and email they're not happy with. I don't know whether they'll accept fax copies. I'll have to check with that, but they still need that original in the end. So that one is probably one that you probably just can't just hold on to and wait. But the fax I'd have to double check. But I do think that you need to figure out a way to get that script to the pharmacist.
Yeah, sure. Madeline's asking, are they able to sign with an electronic signature?
Yeah, that's a good question. I mean, my understanding is it still needs to be an ink signature, but I have a feeling it's state by state, whether the state legislation has changed, but that's one that I'm going to have to take away as well, because we had a discussion in the college about this, and all of us weren't even sure. I mean, I think it's just things have changed so rapidly. But I do think that's one we need to get to the bottom of, because that might just change things for people in the process. But at the moment, it's really the only communication I've seen is really around the ink signatures.
It must be incredibly challenging at the moment for those that have not had an online setup before. So much choice. How do you choose which platform? Is there a thought process of how and why to choose a particular platform? We've got a question here about your thoughts on Health Direct. Now, obviously, you're not an agent for any one of the platforms, but do you have, what platform do you use, and how would you go about if you were somebody choosing a platform right now?
Yeah, so I mean, I do declare a conflict of interest because I've been doing some work for Health Direct on setting up the national coronavirus helpline. So I do have that conflict there. Of course, I'm going to say Health Direct's wonderful because they won't like me if I don't say that. But look, I think I'm a bit agnostic. I mean, our practice doesn't use Health Direct. Our practice uses AutoMed, which is a product that we had because we did our online bookings with them, and then they just said, look, we also happen to have a video we can turn on for you. My advice is just go with what's easy at the moment, because you've got so much other change and you're struggling with so many things. And I truly worry about people's mental health in this whole situation, because you're worried for your own, well-being and safety, and worried about your practice and the financial implications, supervising registrars, keeping your receptionists employed. And you just don't want to add another complicating layer on top of that. The only reason I would say Health Direct is good, without choosing a platform, is because if you've got access to a free healthcare specific platform, then go for it. You don't have to pay. Otherwise, it would be paid versions of the others is the official line. And so then that's just another cost. So I think cost has to come into it. Somebody told me Zoom for healthcare was about $200 a month, which is ridiculous. I don't know that you'd want to pay that. So I think it's weighing up the factors of, what's the cost? How hard is it going to be to implement? Is this something that's available for free? Is there a product that we already use in our practice that happens to have a video add-on that we can just easily turn on? Because that was really our deciding factor, was just somebody came to us and said, we've already got this, we'll turn it on. So I think that's really the deciding thing. But I think you can change this. So what you decide to choose tomorrow doesn't have to be what you're using in 2 weeks or in 2 months. So they are interchangeable. As I said, get the workflow right. And then if you find Zoom is rubbish and everyone will tell you don't use free Zoom, then you might want to switch that out to trying the Health Direct video call. If that doesn't work, try AutoMed. And there's a bunch of others on that list. And my list is not exhaustive. That, there are so many out there. And I think you're going to find you'll be overwhelmed, and there'll be people pitching to you left, right and centre, because obviously all the tech vendors suddenly, want to sell tech platforms to you. But if you really don't want to, think about that, just start with the phone. At the end of the day, doing telephone consults is okay. It's not as great as being able to eyeball the patient, but it's a place to start and gets that worry off you about trying to set up an IT platform straight away, and you can slowly shop around and figure out what it is that you want.
You mentioned earlier that that you can telehealth multiple times a day. So we've got a question here. Is there a restriction like the 2 consults should be at least 3 hours apart, for example?
No, somebody asked that in the webinar today to the department, and they didn't say there was a minimum time period. And you can actually replay that webinar. It's been recorded if anybody wants to listen direct from the horse's mouth. So you can bill twice, but it says you just got to it's just about being sensible and documenting the reason and the time, right? So if it's only 10 minutes apart, they might go, doesn't make sense. But, if it's legitimately, an hour, 2 hours, and there's a real reason for it, and you've written it down and you could justify it, I think at this point, they're not really going around going, how do we nitpick on this? I think they're going, okay, there's blatant abuse by some people and we're going to pick up on that, and everyone else is just trying to do the right thing. And I think if you do the pub test, if it feels right, then I don't think you're going to get in trouble for that.
Yeah, we've also been in an environment where all the telehealth numbers have been and still are bulk billed, but there has been some discussion about relaxing that, potentially allowing for private billing. Is that something that you do in your practice, and how do you manage payment and rebate and those sorts of things?
Okay, so you can't privately bill yet, and the advice today was don't start doing it because it hasn't officially come out. So there are still discussions being had, and it's definitely on the agenda, and they said maybe by Friday, but I think it'll probably be the weekend that they'll make any announcements regarding this. So certainly you shouldn't be privately billing yet. And I think when that happens, obviously there'll be all the issues around, how do you get payments? And that's when some of the other platforms that are healthcare specific do have payment gateways built in. And then you might, be more interested in getting one that has the add-ons. But at the moment, please don't privately bill, because they will be looking for that. Well, the patient won't be able to get their rebate. If you can do a full private, but there will just be no rebate attached to that.
We had a question that came in as part of registration, and it was around how do you safety net a patient, check for red flags without causing concern. Do you have a particular strategy around that type?
Yeah, so it's funny because you always ask them really like scary questions when you're talking to them on the phone and you're trying to do a red flag assessment. But I always say to them, look, because I can't see you in person, I have to ask some questions. They might sound a bit silly, but we need to do it just to make sure that you're okay. And we had to do this all the time when I worked on the after hours GP helpline. You get people ringing about I'm just ringing because I want to know which puffer to give to my child today, because we've got a blue one and a purple one and I can't remember which one's which. And you'd say, look, I have to run through some questions. Is his breathing okay? He's not bleeding from anywhere. He's not going to need chest pain. Like we were really we had to do doctor ABCs for every patient. And you sometimes felt silly, but I think you just caveat with the patient and say, look, because it's a telephone consultation, I have to ask you some questions. They may seem a bit, extreme, but it's just a safety thing that we have to do. And most people are okay with it. And I think you've just got to explain that this is a new way that, of doing care and you need to be more careful.
And how would you go about introducing a supervisor as a registrar and introducing that concept to a patient?
Yeah, so I think it's in the same way. I've had a few registrars ask me this, and I think it's the same way that you would in a face-to-face. Like you would say, look, you've got something there that, is it not straightforward, or I'd really like to get a second opinion or a second set of eyes where you might not get eyes on a phone call, but on a video call. Are you okay if I bring somebody else into this consultation? And you're not bringing someone else into the room, but you're bringing them into the consultation. And I used to do this back at my time in the helpline. Sometimes there would be newer doctors who we were training who would struggle, and they'd just say, look, do you mind if I bring my supervisor or bring someone else into the call? Most people are fine with that. They actually have done it with things like, they're ringing up Telstra and you're saying, I want to speak to the manager, and they bring the manager onto the phone and you're having a three-way call. So I think you've just got to treat it the same way you do in person. And there are functionalities, and you probably went through this with the supervisor session on video platforms where you can add an extra person in and then another person pops in. But I would say you can even mix it. So sometimes what you might be doing is you might be doing a video call right now. So I'm doing a video call with you guys, but I want someone else to listen into what we're saying. I can actually dial them on my phone and they can hear us. They might be able to see us, but they might be able to hear us. So I think the other way to manage is if you can't get it all working, all on video, all on phone, it's okay to have someone on the phone and two of you on the video, and you both, kind of doing the consult sort of mixed medium. So that's also an option as well if people are struggling with that.
There was lots of questions about feeling uncertain about the medico-legal aspect of telehealth. Is there anything that is significantly different in terms of medico-legal issues for telehealth?
Yeah, look, I've done a lot of research over the years because people were very anti-telehealth for a long time, and I copped a lot of abuse for it back that I was involved. And, I read all the literature, did all the searching, and there's no evidence that using telehealth leads to worse outcomes, is more dangerous. There's actually been even more sort of the other way, because it's held almost to a high standard. And I guess because in a lot of services, consults can be recorded. So certainly when I was on the after hours GP helpline, we recorded every consult. Same when I worked at Telstra. The company in Switzerland records every single consult. The ability to go and do audits and to do teaching and to have people, we were forced to listen to our own calls when I worked at all those services. And every week you would have a certain minimum number of calls you'd have to listen to, and you'd realise things that you were doing wrong or things that you missed. So it almost is like, because telehealth has to, kind of defend itself in some way, that there have been more sort of processes around it to make sure that it's delivered safely, that it has, really good outcomes, the same outcomes as, just doing purely face-to-face care. But with the caveats that you don't use it when it's not appropriate, clinically appropriate. So if you're someone who's trying to do 100% telehealth, yes, that's going to lead to bad outcomes. But if you're somebody that figures out this is amenable to telehealth and this isn't, and you've got that balance right, then you shouldn't have any worse outcomes. And the MDOs have all recognised this, and that's why, you should individually talk to them. But from all the discussions I've had with them, they cover you for telehealth services. And, you know, they haven't put anything out saying, look, you know, it's more risky or to jump, you know, put your premiums up or you have to pay extra. So I think we can be comforted with the research.
Yeah, sure. We've got another question here. It's about if you assess a patient by telehealth in the morning and decide they need a face-to-face appointment that evening, is that regarded as a continuation or a separate attendance?
Yeah, that's a really, really tricky one, because we've had discussions with people in the department 2 separate times, and we've had 2 separate answers. So I'm not going to say that I am an expert on this. I personally have done it, and if I'm going to get audited and in trouble, that's fine. But I mean, I did pick up something else on the face-to-face consult that I didn't on the phone, so maybe I can defend myself. But I think it's a bit of a grey area, and I would say that we probably need some clarification from Medicare about that. But to me, it makes absolute sense that we should be allowed to do that, because the whole point is to do that triage to then figure out if we need to see them. But we're spending, you know, the time. So, I mean, if it is a continuation, I wonder if you just end up doing time-based and you figure you've spent, you know, 15 minutes on the phone, you spent 15 minutes face-to-face, and you bill it all as a face-to-face for that time. I'm not sure, but that is one that I honestly can say I don't have a definitive answer for.
The type of thing that it would be fantastic if they could put up some case scenarios actually to provide some guidance. We've got another question here about if a patient had a teleconsult earlier and coming back to pick up a script and examination, should this be charged as the telehealth item or the item 23?
I think that's the same question that we just kind of had, is that, you know, if I mean, when they come in, if they're just picking up scripts, obviously I don't think you can charge for that. But I think if you're actually doing an examination, then obviously you're having a consult with that patient. So I think that's where you need to work out, is it the same issue, is it a different issue? How do you bill a continuation if you already billed the telehealth? I mean, I think that's where, you know, do you wait until the end of the day and then you work out what you're doing with all your patients? I mean, this is stuff that's just changing day to day. And I think it's important to, you know, keep going back to the MBS website, because I've noticed they change things on there all the time, and little things that I like, you know, initially they said the patient had to have been at that practice once in the previous 12 months, and they just quietly removed that requirement, and there wasn't a big announcement about it or anything. And then when we followed up and said, you missed this on the MBS schedule, they were like, oh, it's actually because we've removed it, you don't need to do it anymore. So I think there's a lot of stuff that keeps moving. But I would advise perhaps maybe to come to the next webinar. I think the next one's on Tuesday and Thursday. They have the webinars with the department. Glenn, are you sending those around? Doctors going to those? The GP, SAC?
Yep.
Yeah, so then go to that and just ask that question, because I think that's where you get them answered, really.
And on camera, which is even better.
On camera, it's recorded, it's sent to everyone else, so you can use it as defence one day.
Yeah, we've got another one here, and look, this is an observation which will be frustrating for a lot of people. It's about what do you do if you keep calling patients and they're not responding to the calls? Sometimes you feel like it's a waste of your time. We had this same discussion on Tuesday, and the suggestion was having reception send prompting text messages 10 minutes before your doctor is just about to call you. But how do you handle that, and is there a best practice way to manage it?
Yeah, so look, I think some of the platforms are good like that, because you can, you know, some of the platforms I've seen, the reception can actually just hit a button and it pings the patient to say your doctor's almost finished with the previous patient. They don't actually need to pick up the phone, and that goes directly to the patient via the app or the service they're using, or to their email, or via an SMS. So I think it's really platform sort of centric about having those extra services. And this is why some of the ones that have waiting rooms are good, because they do notify people that your appointment is coming up and get them ready. I think it's also setting expectations with patients and saying, you know, we will call you twice, but, you know, if you don't come to that appointment, you may, and I'm not sure whether you're allowed to do cancellation fees in this environment, but I think it's just, even if you, even if you just put it as a policy, you know, for booking a telehealth appointment, that you do require them to be available, and that you'll only try twice, and then, you know, that they've kind of given up their appointment. But it's going to be one of those things that's going to be challenging. I mean, luckily for me, the technology that I use happens to allow us to ping the patients to tell them, and they've all been pretty good at turning up. But I think also the point is the other way around, where we've had the issue where I've been running late, and normally when you're running late and the patient's sitting in the waiting room, they kind of are there and they sit and wait. When they're at home, it's weird. You'd think they'd be busy doing other things, they wouldn't care, but they start ringing the practice incessantly, and it's like, the doctor's only 10 minutes late. Normally you'd sit here for half an hour before you came up and said something at the front desk. But it's just weird how people have got to kind of adapt to a new way. And we've had some patients be abusive, going, I've been waiting 10 minutes sitting at my desk. And she's like, well, you're at home, aren't you? Like, what's the big deal? So I think, again, setting the expectation, it's all in the communication to the patient. So we've now written communication that says, please treat this like you would in your normal, you know, in the normal setting where you come into the practice, where sometimes the doctor is running late. So just because you have an appointment at 8:30 and you're expecting a phone call or a video call, it might be, you know, 8:45, and, you know, at least wait 15 minutes before you start calling the reception desk. So things like that we've had to put in place.
Do you keep your patients on the line, photo, video, while you're completing consultation paperwork, like scripts and the likes?
Yeah, so I tend to keep them on the line just in case there's something we need to clarify, or we need to double check, or I pick something up. I wait until I've completely finished, because there's also a timer that's linked to the notes, and so I complete it all together. If I leave the room, I put them on mute and I say, look, I'm stepping out for a minute. You know, I have to go to the reception desk and we're sending some stuff off, and then I'll be back just to tell you that we've done everything that we need to do. Some people don't do it that way, and they like to hang up on the patient and do it all afterwards. But I just prefer to just have them there and just constantly communicate with them, because sometimes they're like, you forget that they're not sitting in the room and they can't see you walk out to the reception desk. You actually have to tell them and say, I am now doing X, Y, Z, or you're going to hear me printing stuff. Sometimes that's been the mistake. You know, it's just something got really noisy and they're like, what's going on? I'm like, that's just a printer. So it's a communication thing. And the more you do it, the more you get used to it, which is why sometimes a video is good, because they can see you get up and say, look, I'm just moving, you know, to the reception desk, or I'm just getting this off the printer.
Do you use a headset, and do you recommend getting one?
So I think if you feel comfortable using a headset, I would advise doing it. I mean, most of my telehealth work over the years has all been with headsets, and I've really lived them. I'm not using one tonight, but some people find them a bit restrictive and and if you're going to get one, try and get a wireless one, because the worst thing you do, I've done this a lot, is if you have the wired ones, you get up to go to the printer or walk out the door and you pull the whole computer with you. So if you're going to get them, I'd advise getting a good wireless one if you can find one.
That's fantastic. Indeed, thank you so much for making your time available. There will no doubt be more questions. We are, however, quite over time, and thank everybody for giving their time, and in particular you. I know that everybody online is very grateful for your insight and experience and sharing that with us tonight. For those of you who have enjoyed this webinar, we have sent out an email to your inbox to ask you about what you enjoyed about this webinar and what we can do better next time. So please do take 2 seconds to fill that out. We do use it to improve all of our webinars. And we'd like to acknowledge the funding and support that has been made available by the Australian Government under the Australian General Practice Training Program. Indeed, thank you very much.
No, thank you for having me, and good telehealthing, everybody.
Good luck, everybody.